Hello guys, welcome to our channel Inspiring Minds. So I'm here with a new lesson, that is anatomy of the ear.
We know that the journey to becoming a doctor can be difficult, and we are here to help. Through these videos, we will walk with you every step of the way, helping you become a better doctor. Why do we think we can help? Because we're aspiring doctors just like you, who have been there and experienced these difficulties. Make sure to subscribe to our channel, like this video, and hit the bell icon. Welcome to Inspiring Minds.
But before going into the discussion about the anatomy of the ear, I want to discuss something about the past question which I have asked you in the anatomy of the nose. So I have asked you one question, that which is the most common site or the most common reason for the posterior epistaxis in an adult male. So many of you have answered hypertension. I want to clear one thing, that earlier it was believed that the hypertension was the reason for the posterior epistaxis in an adult male. However, it is not true. Hypertension per se does not cause any sort of posterior epistaxis. So you might be wondering, then what is the answer? Answer to this question is very clear. It is due to panic attack in hypertension. Panic attack in hypertension, or it may be due to any weather change condition, it may be due to any other reason, but hypertension per se does not cause posterior epistaxis. Now for the next video, I want to ask one question related to posterior epistaxis, that which is the most common artery causing posterior epistaxis. So in the next video, I will see to this question. Now let's discuss about the anatomy of the ear. Before going into the anatomy of ear, I want to recommend some of the high yield point for you. During the video, please increase the speed of the video, bring it to 1.5x and then see the video. Try to take some of the note points. Don't try to copy the notes as it is. Try to pick some high yield points and then refer some of the standard books like Dhingra or Mohan Bansal, or you can go for an review book like Buddhi Raja or Sakshi Arora. So without any delay, we are going to start about the anatomy of the ear. So in the anatomy of the ear is divided into three parts: external ear, middle ear and the inner ear. So in the diagram you can see pinna, external auditory canal and tympanic membrane are the parts of the external ear. In the middle ear cleft you can see this is the middle ear. Middle ear consists of a cavity, three bony chains, three bony ossicles or an bony chain, and then eustachian tube, posteriorly mastoid. These are all the part of the middle ear cleft. We are going to see middle ear in the subsequent video, and in the later videos we are going to see about the anatomy of the inner ear. So we are concerned in this video about the external ear, that is pinna, external auditory canal or known as EAC, and tympanic membrane. So in the video I am going to use EAC for external auditory canal and TM for the tympanic membrane. So let's discuss about the pinna. So how the pinna is developed, development of pinna. So as we all know, during the developmental phases, during the embryonic phase, there will be formation of 6 pharyngeal arches. Among the 6 pharyngeal arches, that is they are named as 1, 2, 3, 4, 5 and 6. The 5th pharyngeal arch undergo degeneration. So there are in total 5 pharyngeal arches. Each pharyngeal arch has a pharyngeal cleft, which is mainly the ectodermal component, and pharyngeal pouch, which is an endodermal component, and the middle layer, which is a pharyngeal mesoderm. So in this diagram you can clearly see this is pharyngeal cleft, this is pharyngeal pouch, and this is mesoderm. So the mesoderm of the pharyngeal arch consists its own artery, its own nerve supply, and its own cartilage. Okay, so the next point is how the pinna is developed. So from the first and the second pharyngeal arch mesoderm, you should be very clear, from the first and second pharyngeal arch mesoderm, there will be development of 6 swellings. These swellings are known as hillocks of His. These are known as hillocks of His. Be clear. So the first swelling is developed from the first pharyngeal arch, and the remaining 5 swelling develop from the second pharyngeal arch. So the first swelling leads to the formation of the tragus, and the remaining 5 swelling leads to the formation of the remaining pinna. You can see that in between the first swelling and the second swelling, there is a region in which there is no cartilaginous portion. This portion is known as incisura terminalis. Incisura terminalis. As there is no cartilaginous portion in the incisura terminalis, we can give an incision over this side. This approach for the tympanic membrane or to the middle ear from the incisura terminalis is known as end oral approach. It was developed by Sir Limpert, hence it is also known as Limpert end oral approach. In the video of instruments, we are going to see what are instruments required for the Limpert end oral approach. In this part, you must only remember that in between the tragus and the ascending crura of the helix, there is a portion in which there is no cartilaginous part. It is known as incisura terminalis, and through incisura terminalis, we can approach the middle ear by a Limpert end oral approach. And the incision is Limpert end oral incision. Okay, so this must be clear to you. This is the development of the pinna. So let's discuss about the parts of the pinna. So what are the parts of the pinna? So let's label them together. This is known as tragus. Tragus developed from which pharyngeal mesoderm? First pharyngeal mesoderm. Very good. Next, opposite to tragus is in part. So anything opposite is known as anti. It is opposite to what? Tragus. Hence it is known as anti-tragus. Quite clear, very simple, very logical. Now this portion is helical in shape, hence known as helix. Now just opposite to helix, that is anti-helix. We can see this. Okay, so this is anti-helix. At the end of the anti-helix, you can see a triangular depression. This is known as triangular fossa. Just above this, you can see a scaphoid fossa. You can see what? Scaphoid fossa. Now, another very important structure which is known as lobule. Why lobule is so important for us? Because lobule does not contain any cartilage. Lobule is just an fatty portion. Okay, we'll come to the clinical aspect related to this in few minutes. Now the central depression is known as concha. This whole portion is known as concha. Okay? So concha is divided by ascending crura of helix. This is helix. This is ascending crura of helix. So ascending crura of helix divides the concha into this part, which is known as Simba concha. What is this known as? Simba concha. Okay, I'm not able to write the whole spelling. I hope you are clear with this. Just keep on clearing your concepts. You will be able to see all these things in your standard book. So this is known as Simba concha. The lower portion is known as meatal concha. So what is the importance of Simba concha? Just consider you are seeing a patient of acute mastocytitis. When there is acute mastocytitis, when we press this portion, Simba concha, there will be tenderness at this side. So Simba concha is an anatomical landmark for mastoid tenderness. So you can see the mastoid tenderness at Simba concha. That means it is an anatomical landmark for mastoid antrum. Now my question to you is, what is the surgical landmark? What is the surgical landmark for mastoid antrum? So when we approach the mastoid antrum, we are able to see, let me give 1 second, I'll explain you. So let me label this. This is mastoid. This is mastoid. This is meatus. Above you can see the zygomatic process of temporal bone. So this is the part. So we have lifted during the mastoid surgery. We have given post-oral incision. We have given an incision behind the ear while these post-oral incision, and we have lifted the skin. Now we are at the bony landmarks. So this is an inferior temporal line or superior temporal crest. This is superior temporal crest. This is the posterior superior segment of meatus. Now what we do, we draw a tangent such that it cuts both of this line. So what we got in this center portion, the triangular area, this is known as McEwan's triangle. Named after Sir McEwan. So McEwan's triangle is a surgical landmark. That is, after giving incision, removing of the skin, then we start drilling at the McEwan's triangle to reach the mastoid antrum and to remove the disease from the mastoid antrum. It is quite clear. I think there is no doubt in this portion. So this is McEwan's triangle. So what is the clinical aspect related to this is first Simba concha is the anatomical landmark and McEwan's triangle is surgical landmark. So clear this concept in your mind. A question can be asked in other way around. So we were discussing about the parts of the pinna. So the parts of the pinna are tragus, antitragus, helix, antihelix, concha divided into two segments, that is Simba concha and the meatal concha, and then lobule, scaphoid fossa and triangular fossa. Anatomical landmark for mastoid antrum is Simba concha and surgical landmark is McEwan's triangle. The boundaries of McEwan's triangle are superiorly by the inferior temporal line or the superior temporal crest, inferiorly by the posterior superior segment of the meatus, and posteriorly by a tangent from the meatal segment cutting both the lines. The triangle formed is known as the McEwan's triangle and it is a surgical landmark for the mastoid antrum. So now my question is, mastoid antrum is completely developed at birth. True or false? First question, mastoid antrum completely developed at birth. True or false? Second question is, mastoid process completely developed at birth. True or false? I will discuss this question in the subsequent video, so be connected with us for many such confusing and high yield points. So let's discuss about the next point. What is the nerve supply of the pinna? Quite simple. Tragus is developed from which arch? I hope you are clear. First pharyngeal arch. Okay, first pharyngeal arch. So what is the nerve of the first pharyngeal arch? I have told to you that every arch has its own nerve supply, cartilage and the blood vessel. So what is the nerve of the first arch? So I hope you all know that is the mandibular nerve, which is a third branch of the trigeminal nerve. I hope you are clear with this. If you want to make a video on this topic, you can write down in the comment section. First pharyngeal arch lead to the formation of the first pharyngeal arch has a nerve known as the mandibular nerve. Mandibular nerve after exit give a branch which is known as the auriculotemporal nerve, and this auriculotemporal nerve supplies the tragus and some part of the ascending helix. You can see from the diagram. So first point is quite clear that auriculotemporal nerve leads to the supply of the tragus. Now most of the portion of the helix and antihelix is supplied by greater auricular nerve. I repeat, greater auricular nerve. This concept is wrong. There is no such concept like greater auricular nerve. We use the term greater auricular nerve when there is something lesser. We don't have lesser auricular nerve, hence it is correct. It should be correctly labeled as great auricular nerve. I know most of you might have not noticed this, but this should be remembered that if there is an option greater auricular and there is an option great auricular, you must be clear that there is nothing like lesser auricular nerve, and hence the answer should be great auricular nerve. So the great auricular nerve supplies the lobule, helix and the antihelix. So, and it also supplies most of the medial part of the pinna. So I hope you are clear. Now the remaining part of the meatus and the posterior part. So great auricular nerve is a nerve supply of the helix, antihelix, lobule and most of the medial portion except the superior part or the medial portion, which is supplied by the lesser occipital nerve, Now be clear, it is lesser occipital because we have something greater occipital. We are going to see in the neuroanatomy when we will discuss about the scalp nerve supply. So the upper part is supplied by the lesser occipital nerve, and the medial portion, that is the retroauricular region, is supplied by 7th nerve and the 10th nerve. So what is the cranial number 7? That is the facial nerve. Facial nerve gives an sensory branch which is known as nerve of Risberg, which supplies the retroauricular region of the pinna, posterior part of the external auditory canal. If this is external auditory canal, then the posterior part is supplied by the nerve of Risberg, and also tympanic membrane posterior part. Along with this facial nerve, it also accompanies vagus nerve. The branch of the vagus nerve is known as Arnold's nerve, or it's also known as Elderman's nerve. Now let's discuss some of the very interesting and high yield points related to this nerve supply. The nerve of Risberg, it is the sensory branch of the facial nerve. When there is acoustic neuroma, I hope you know about the acoustic neuroma. If you don't, we'll see this in the clinical section of the ear. So in the acoustic neuroma, that is when the Schwann cells of the inferior vestibular nerve, this is inferior vestibular nerve, it start growing, then it will compress the facial nerve. So let me take from the start. Consider this is the internal auditory meatus, which is in the posterior slant of the petrous part of the temporal bone. Internal auditory meatus is divided into superior and the inferior respect by the falciform crest. Now the superior part is further divided into anterior and posterior part by an bar which is known as Bill's bar. Now Bill's bar was discovered by William H. House, who is also known as father of neurootology. He is the Nobel Prize winner for the cochlear implant. You must know this point. Then Bill's bar divides the superior part into the anterior and the posterior part. Now the anterior part has a nerve. This is facial nerve. This is facial nerve. The posterior part has a nerve which is, this is superior vestibular nerve, and the inferiorly there is inferior vestibular nerve, and inferior, in the inferior quadrant anteriorly there is cochlear nerve. So we can say that in the internal auditory meatus there are two nerves, 7th and 8th nerve. 8th nerve has two segments, vestibular and cochlear. So cochlear is present in the inferior part anteriorly. Vestibular nerve is divided into two parts, superior vestibular and inferior vestibular. Superior vestibular is present posterior superiorly and inferior vestibular is present posterior inferiorly. So I am clear. When there is growth of this schwannoma, it will compress the facial nerve sensory branches. Why sensory branches? Because motor branches are quite resistant to pressure. So it will compress the sensory branches. When it will compress the sensory branches, the sensation which it was carrying from the posterior superior aspect of the meatus will not be able to carry. When they will not be able to carry the sensation from the posterior meatus wall, there will be hyposthesia or anesthesia of the posterior superior part of the meatus. Okay, so this sign is known as, this is very high yield point, Hitzlsperger sign. This is known as what? Hitzlsperger sign. Hitzlsperger sign. Hitzlsperger sign. So what is Hitzlsperger sign? Hitzlsperger sign is hyposthesia or anesthesia of the posterior superior part of the meatus due to the compression of the sensory branch of the facial nerve, that is nerve of Wilsberg, due to the acoustic neuroma. I hope you are clear. So what is the second important point related to the nerve supply? The second important point is while syringing. Now what is syringing? We'll clear all the concepts. What is syringing? Consider this is the external auditory canal. This is external auditory canal. If there is a wax or the mass impacted in the isthmus of the external auditory canal, we are going to see what is isthmus in a few seconds. So we have to remove this wax. So what we will do, we will inject a jet of water in the posterior superior direction. In the posterior superior direction, and that water will return and it will remove the impacted wax or the foreign body or anything. Please note, do not do syringing in some condition which is highly important. If the wax is impacted in the meatal recess, if this is organic body, so what will be the problem with the organic body? In the organic body, it will absorb the water and it will become swollen and it will completely obstruct the lumen and thereby making the removal difficult. So you must remember that when the mass is in the meatal recess or when the mass is organic, we have to not do the syringing. What are the other contraindications for syringing? If there is perforation in the tympanic membrane, if there is past history of the CSOM, if there is an acute inflammation. Why we have to not do syringing in the acute inflammation? Because in the acute inflammatory state, when we will do the syringing, it will be a quite painful condition. So what are the contraindications for syringing? Let's write this together. What will be the contraindication for syringing? Point number 1, when the wax is in the anterior meatal recess. What will be the point number 2? When the foreign body is organic foreign body, because organic foreign body will take up the water, it will go under swelling and it will lead to the complete obstruction of the lumen and thereby making the removal difficult. This is point number 2. Now what is the third? If there is an acute inflammation. Point number 4, if there is tympanic membrane perforation. What is the problem with tympanic membrane perforation? We'll inject water and we will predispose the middle ear for the middle ear infection. Okay, so you must be clear with this. In which direction we do syringing? We do syringing, that is jet of water is injected in the posterior superior direction so that it is reflected in the downward direction and lead to the removal of the foreign body. So this is about syringing. So what happens in syringing? When we do syringing, the external auditory canal, which is also supplied by Arnold's nerve, which is a branch of the vagus nerve. This vagus nerve undergoes stimulation. When this vagus nerve undergoes stimulation, it will lead to a cuff reflex. So you must remember this point. The cuff reflex which happens in the syringing, it is due to the Arnold branch of the vagus nerve and not due to auriculotemporal or facial nerve. Okay, so it happens due to the cuff reflex. It causes cuff reflex, and this is the reason we use the water for the syringing which is at the room temperature. We cannot use any other temperature because it will lead to the unnecessary stimulation of the Arnold nerve and thereby intense cuff reflex. So what are the points related to the syringing? Point number 1, we inject the water in the posterior superior direction. The temperature of the water is at, sorry, it's not room temperature, it's at the body temperature. I'm really sorry for that. It is at the body temperature. The temperature of the water should be equal to the body temperature, that is 37 degrees Celsius. And what are the contraindications for the syringing? Acute inflammation, perforation in the tympanic membrane, wax impacted in the anterior meatal recess, or organic foreign body. In these conditions we cannot do Heisenberger sign, which is the seen in acoustic neuroma. This point you must remember regarding to the sensory nerve supply of the pinna. There is one more very important topic related to the nerve supply of the pinna. We are going to see it. So you can see this is the piercing of the ear. Now this has become a quite fashion. So in earlier days we used to do piercing of the ear in the lobule. Why in the lobule? Because lobule is fatty. It is fatty. So when we do the piercing, it is not that painful. But with the modern with the modern fashion, we have started piercing in the various other part of the ear, and as we know, the other part of the ear contain cartilage, and above the cartilage there is perichondrium, which is a nerve supply. So whenever there is a nerve supply and we will try to pierce it, that will cause intense pain. So as we will do piercing in this segment or in this segment or in this segment, it will cause pain. So we have to reduce the pain. So what we do, we give the anesthesia over the nerve supplying the region, and then we do the piercing. We keep the patient on the antibiotic to prevent the infection and the inflammation, and after some time the perforation becomes permanent, and then we can use this ornaments. So in which nerve we have to give the anesthesia? Now this has become the point of question. Now we can ask various questions. Now if I ask you one question, that if I want to do piercing on the tragus, then which branch will be given or will be anesthetized? Very simple, auriculotemporal nerve. And if I am asking that if I want to do the piercing in the helical region, then great auricular nerve will be anesthetized. Great auricular nerve. So this is the concept you must remember. Now the next point is, if we are doing in surgery which is known as rightedectomy, what is righted? Righted is facial wrinkles. You can see these are the facial wrinkles. If we want to remove the facial wrinkles, we give an incision in the post-oral region and we lift the skin. We lift the skin to remove the rhytids. This is known as rightedectomy. So we have to give an incision in the post-oral part. The post-oral part is supplied by great auricular nerve, and hence we give the anesthesia on the great auricular nerve. Great auricular nerve is given anesthesia in the process of rightedectomy. Rightedectomy. I hope you are clear. Rightedectomy. So these are the points. These are the clinical points related to the pinna and its nerve supply. So we have completed with the pinna, its development part, various anatomical and surgical landmarks, and the nerve supply of the pinna.